Good evening all, and welcome to this evening's webinar with Dr. Jake Cooke. I'll hand you straight over to Jake, but would just like to say if you have any questions throughout the webinar, please do type them in the chat box and we will try and answer them as and when we're going along. Over to you, Jake.
Great, thanks so much. So good evening, ladies and gentlemen. Today we're going to be talking about radiating arm pain, numbness, and how to go about differential diagnosis. So on Saturday, I will be talking on a similar subject, but talking about whiplash and how it develops from acute to chronic pain. So I'm going to try not to cross over too much, but of course, when we're talking about radiating arm pain, whiplash can be a cause of radiating arm pain. So we are going to cover some of those subjects. So let's put the old slideshow on. Oh, instant failure. Good. Let's try this again. Give me 2 seconds. Let's try that again. Better. I apologize that you got the Google Docs tab up at the top there. So let's talk about case registration, and ideally I want you to make notes on this so you will learn more and remember more if you're actively involved, and if you're just passively watching, you know, while you eat some dinner or have Netflix on in the background, you're definitely not going to remember anything. So pen and paper, and I want you to come up with a list of 3 differentials for what you think this case could be. So a 34-year-old male presented with chronic left proximal shoulder pain. He had radiating pain into the ulnar aspect of his lower arm and hand. So when I say ulnar aspect, I mean all the way up through here. But he complains that his whole hand is numb. So pain going into the ulnar aspect of his hand, but the whole hand is numb. He noticed that the shoulder and arm pain was worse at work, but his hand is worse at night. So this guy's an accountant. He spends all the time at a desk, shoulders flexed. And when he's at work, it gets worse. And that pain is going into the ulnar aspect of the hand, but the numbness is not worse. He notices the numbness gets worse at nighttime. Exercise also provokes that shoulder pain. When that shoulder pain gets worse, the pain down to his arm gets worse. He denies any neurological signs, symptoms in the lower limb, no change in bowel, bladder, no other red flags. Basically, apart from that, nothing else going. Now, I'm not going to give you any more details on the examination because I want you to start thinking for yourself, what would you be looking for? So I'll give you a few seconds to think about differential diagnosis. So pain, proximal shoulder pain, he points to kind of this area. It's traveling down into the ulnar aspect of his arm into the fingers. That pain is worse during the day when he's at work at a computer or at the gym. He does in the gym workout would generally be like a weights workout. So, you know, bench press, pull-ups, all that kind of stuff. At night time, however, his whole hand goes numb. Give you a few more seconds and then we'll talk about differential diagnosis as a broad theme. So how do we crack on with differential diagnosis in the first place? Okay, hopefully just churning out, well, one very specific diagnosis and a whole bunch of other really good ones. So when we're looking at differential diagnosis, we always want to think, first of all, very simply, is it broken? Is it broken? Yes or no? That's the first thought that goes through your head when the patient is telling you their history. And again, when you're doing examination, is it broken? By broken, I mean, can they move it or can they feel it? If they can't move it, they can't feel it, then it's broken. And they probably want, well, they definitely need to be referred out for further testing. So if a patient comes in and they say, I'm complaining of hand numbness, and you go and do your pen wheel and they're like, no, can't feel anything at all. Or you do your soft touch, like, no, really can't get anything. We will show you why we want to think, well, we want imaging, we want nerve conduction studies, we want other professionals to have looked at this and done their homework, so that at the very least, it's not our neck on the line if something goes wrong, but also to find out why something so severe would happen. The vast majority of patients that are going to see us as chiropractors or as manual therapists, they're not going to be broken. They're going to be mild to moderate weakness or sensory loss, but it's rare that we're going to see really severe stuff. So assuming it's not broken, we then just think, is it too much or too little? Is there too much activity there or too little activity? Is there too much pain or too little pain? So I could complain of numbness in my hand, and we want to know what is the exact quality of that numbness. Is it that we're actually getting too much sensation? So a classic one would be, say like a migraine, where someone might complain of tingling in their face, where actually they're getting a positive symptom, not positive, negative symptoms. Negative is there's a lack of sensation, positive symptom is there's too much sensation. So that's basically what we want to look at. So if someone's saying it's pain, is it there's too much pain, or is it too little pain? Is there too much sensation or too little sensation? And then very simply, what level? So this chap is saying his whole hand is numb. We show you why you want to think, well, what level would account for that? Could it be a C5, C6, C7 nerve root lesion? Would C7 do the whole hand? No, not really. So we want to think through those levels. Is it out in the peripheral nerve system, out in the peripheral nerves? Is it the level of spinal nerve roots, spinal cord, brainstem, subcortical areas or cortical areas? And again, for the vast majority that we're going to see, it's going to be peripheral nerve roots or spine. So once you have an idea of what the level is, we just want to think, what is the cause? Now, I would advise that you have somewhere on your notes or somewhere on a spreadsheet that you can check easily the word vindicate. And at the end of a new consultation, once the patient has left and you've already done your diagnosis, you've done all the other stuff, you're going to run through vindicate and just try to think, could there be another explanation? So very simply, vindicate is there a vascular, infectious, neoplastic, degenerative, iatrogenic or intoxication, congenital, compressive, autoimmune, traumatic or endocrine cause? So again, as chiropractors, the vast majority of things that we're going to see are going to be degenerative, compressive or traumatic. The problem with when you see those three all the time is we have these learning processes that allow us to have quick, rapid thought that relies on assumptions and bias. And it's going to be very good a lot of the time, but sometimes it's going to lull you into making mistakes. So I think it doesn't matter how much experience you have, you always want to go back to that and say, okay, it just looked like it was a C5 nerve root lesion, probably compressive from a disc or something like that. Could it be vascular? If it was vascular, how would that picture be different to the way I'm seeing it now? Okay, if it was infectious, how would that be different? Did the patient complain they had night sweats, fever, was anything like that? No, okay, what was that? Could it be a tumor? Is there a neoplastic cause there? Have they got a history of cancer? Is there a history of smoking? Is there anything else like that in the family? And just getting yourself into that habit, just going through that list and thinking, no, I'm pretty happy. It's just a compressive C5 nerve root lesion. Hopefully you won't ever use it, but every so often you'll find yourself thinking, actually that patient with the radiating arm pain, they did complain the pain was under the armpit. Do I need to go and get them to have a breast exam? Last time I taught this similar course a couple of weeks ago. On the Tuesday, I get an email from one of the guys attending who's like, "Oh, so does this look like a Pancoast tumor?" Because the patient's come in with all the symptoms we're talking about, and you can see on the X-ray something certainly looks a bit suspicious. So just sitting down and not thinking, "Oh, it's just TOS, it's compressive from the scalenes," but thinking, going through that list and thinking, "Could it be a neoplastic?" Actually, yeah. So when we talk about this patient with chronic pain, we want to think, well, what is chronic? In terms of research, in terms of historically how we use it, chronic pain is time, right? We've got the god Chronos, Father Time, who, and he's kind of passed his name down. So we think of chronic pain as anything that's been longer than 3 months. The problem is in research, we also use chronic pain to denote pain that's no longer associated with the presence, intensity, or duration of a tissue injury. So basically, I've torn my supraspinatus. It's 6 months later. You take an ultrasound, that muscle is repaired, lovely, everything's looking great, and yet my pain is worse than ever. That's something we're going to see all the time with our patients. So in chronic pain, we're going to see an upregulation of pain sensitivity and a downregulation of pain inhibition. Basically, we're going to learn to be more pain sensitive, and unfortunately, we're going to lose some of that pain inhibition. The natural state for the human body is to inhibit pain far, far more easily than we pass it on. So if you do it now yourself, you can pinch your finger pretty hard. I can go I can pinch as hard as I can without really feeling any pain from that, because my brain is inhibiting it. It knows that I'm the one doing it. It knows there's no foul play. If you were now to hand your finger over to your partner and ask them to pinch, you're going to feel that pain a lot quicker, because you suddenly lose that descending inhibition. You lose that pain inhibition. So the natural state is we inhibit pain far, far more easily than we excite pain, that we allow it to pass on. So in chronic pain, normally we're talking about central pain sensitization, CPS. And CPS is occurring in the spinal cord and up. So spinal cord, brainstem, brain. But we do also get changes out in the periphery. So the actual first order neuron that will take the pain from that injury site to the spinal cord actually becomes faster. So it's going to grow new receptors so it can detect the level of injury more efficiently. And then the actual nerve becomes a little bit more, the myelin gets a little bit thicker so it can pass that pain signal along faster. You would have seen patients like this where they are just a little bit too sensitive. Everything you touch, oh, well, that's sore. And if you're not feeling very patient, it can be annoying when you're just trying to do it and you're just trying to, do your palpation, do your assessment the whole time. That, oh yeah, that's it. Oh, don't touch it. Oh, that's painful. It could just be they've had this pain for a long time and we've lost that descending pain inhibition. We've got that upregulation of pain speed and sensitivity. So that occurs in the periphery, but it also occurs in the spinal cord, in the central structures. So CPS is found in whiplash, low back pain, fibromyalgia, subacromial impingement syndrome, tension type headache, osteoarthritis, rheumatoid arthritis, lateral epicondylitis, patellar tendinopathy, and the list goes on and on and on. So basically, if you've got pain in any part of your body, the CPS can occur. So what causes it? The intensity of pain. That is a huge part of this story. So part of the reason I'm talking about whiplash on Saturday is because in whiplash we have that brutal, sudden sprain of the neck, which is hard to reproduce in other scenarios. So we get this rapid, brutal pain bombardment going from the facet joints into the dorsal horn and spinal cord, and basically screaming pain. When we have that high intensity of pain, that can trigger these changes in pain processing very, very quickly. So in rat studies, it's 4 hours. So they give poor Mr. Rat a little whiplash. They go in and they immediately anesthetize it. If they do it immediately, the rat heals and has no signs of chronic pain. If they leave it just 4 hours and then go in and put the anesthesia in, it's too late. The pain process is already there, and poor Mr. Rat goes on to show all the signs of pain sensitization. And it appears to be similar with us. Now we have we're bigger and we have slower metabolism, so unfortunately there's no study. Well, fortunately there's no studies where they've gone in and intentionally given someone whiplash to see how quickly they develop pain. But let's assume it's days. So we've probably got a matter of days from the point you have high intensity of pain to these CPS processes occurring. The duration of pain is essential. So I can have an injury that actually wasn't that intense, but the tissue injury was enough that it's gone on for a long period of time. When we have that constant bombardment from first order neurons hitting the dorsal horn of the spinal cord saying, ouch, 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 that chronic bombardment is enough to slowly produce these CPS changes, and you end up with the same result. Someone that is much more sensitive to pain than they should be. Context of pain. So, pain science is still a very hot topic, and this is one of them. The context of pain is so important. So if I'm a taxi driver and I've had a whiplash, and it now means I can't drive my car because I can't turn my neck to drive safely, and I've got a family of 4, and I'm the sole earner. Actually, the context of hurt my neck, I can't work, that is a substantial player in whether we develop chronic pain or not. Versus, I've had a whiplash, but actually who cares? I work from home anyway, it doesn't really affect me. It'll get better when it gets better. So context is really important, and psychological factors. Depression, anxiety. So someone who's highly neurotic, or that's never sounds like a nice word, but someone who has a neurotic type personality, highly anxious, or unfortunately suffering depression, again, they've lost a lot of that pain inhibition in the first place. So when an injury does come along, they're more likely to develop into chronic pain. So, terrifying word, pathophysiology. Now, we're not brain surgeons, right? We're not surgeons. We don't need to know, we're not chemists. We don't need to know all the minutiae here. So don't worry, this is going to be hopefully a pathophysiology friendly lecture. We've already talked about this. So we get that persistent afferent nociceptive input. A really difficult way of saying it's just where we have a persistent barrage of pain signals coming into the spinal cord. We have something called NMDA receptors. So I'm sure you're used to this. NMDA receptors are long-term potentiation. They are the way our body adapts and learns. So learns new behaviors, learns new skills. So what happens is we have a receptor on the second order neuron. So first order neuron comes in, and when it synapses, its goal is to say tag and get the second order neuron to pass that signal further on. One signal is not enough. So what has to happen is you have a barrage, or you have a lot of nerves summating or clustering onto one, onto the same place. So there's a high barrage of energy, for a better word. So there's a lot of signals coming in saying, tag, please pass this on. If we get a big intensity or a big barrage of them, what can happen is these NMDA receptors have a little plug that stops them being activated, stops that long-term changes in behavior, because really homeostasis kind of wants to keep us the same as we've always been. We're doing well. So when we get a high barrage of pain signals, that electrical storm is enough to unplug the NMDA receptor. That allows calcium and other inflammatory cytokines to flood into the cell and basically make that second order neuron swell and become a little bit more reactive. So next time a pain signal comes along, it takes less energy to get that second order neuron to pass it on. So the first time the pain signal comes in, the second order neuron is resistant to passing it on. So the first time it's resistant, second time it's a little bit more like, oh yeah, fair enough. If that process keeps occurring, unfortunately, when we get that the calcium into the cell, we get genetic changes or changes in the expression in the cell. So it puts on new receptors. It puts on new NMDA receptors, which then themselves become unplugged, which it drives more long-term potentiation. So we get stuck in this horrible system where you get increasing excitability. And because it's more excitable, it gets more excitable. At the same time, we're losing those pain inhibitory synapses. And so it gets worse and worse. So the inhibitory synapses are almost 10 times more common in the dorsal horn of the spinal cord than the excitatory ones. So as a pain signal comes into the dorsal horn that says tag, there's 10 times more synapses there saying don't pass it on, second order neuron, don't pass it on, we're not interested, than there are saying go for it. As that pain excitation starts to occur, we lose those inhibitory synapses. God, tongue twisters today, and we gain excitatory ones. Now, I've not seen research to show that they switch, but that just they go from an extreme down and much closer like this. This can become so prolific that if someone has suffered a cervical facet sprain, they could literally be sitting perfectly still, doing nothing to aggravate pain at all, and they can get a spontaneous discharge of those second order neurons. So I've had a whiplash, or I've torn a shoulder muscle or something like that, and I'm sitting perfectly still, minding my own business, good posture, nothing you could ever accuse me of doing, and my neck could just hurt because those neurons are so spontaneous, so reactive, that whenever leftover neurotransmitters are in the synaptic cleft, because they don't all get cleared out. So you've got some just random ones floating around, and they just bump up against the second order neuron, and it goes, yep, sure, pain. We also get something called after discharge. So you poke me, and I'm like, ow, that's really painful. You take my finger away for the next few moments or minutes. I'm still like, oh man, it still hurts. I can still feel where you poke me. And you would have seen that a lot in your neck pain patients and in your headache patients, right? You feel up underneath subscap, maybe over nerves like the greater occipital nerve, lesser occipital nerve, and you poke them, take them away, and then for the next few minutes they keep complaining they can still feel where you poke them. That's what's occurring in that process. it's important to know this stuff, right? Because how easy is it to help someone if they're at that level of pain? It's not gonna be the same as it's a 5 out of 10, crack, oh, you're all great. You need to know that this is going to take a longer time to heal and to be able to pass that information on to the patient. So these physiological changes occur at the level of injury and below it. So that means that if I have a whiplash at C5, or I just have pain in C5 dermatome, so let's say shoulder pain, I've got a supraspinatus strain, I've got pain in that C5 dermatome, that's going to be synapsing at C5. The pain is then going to spread down into C6. So now I actually feel pain in the C6 dermatome, and I'm more sensitive to pain from that area. So originally you're poking me here, I'm like, oh, that's really painful. Now you start poking C6 dermatome, so coming down into here, I'm like, oh, that's really sore as well. We talked about this earlier. So this is where they went in and blocked, put an anesthetic in straight away, and they find that in rats there's no change. Poor rats, they do happen all the time. They've also deliberately and maliciously stressed out rats, so who are in no pain, that they just stress them out, and they actually find you get increasing nerve conduction velocities as well. So those nerves, those peripheral nerves get faster, which is interesting. So you can have a patient who's just highly stressed, actually hasn't had a bad injury, they're just highly stressed, and they are also primed for chronic pain. So you've got someone who is just more sensitive to pain than they should be, and then an injury comes along and they feel it much worse than they should. Because it's already feeling much worse, they get more higher intensity, longer duration, and then CPS develops. So predictors, we talked about this earlier, so I'll fly through this bit. So sensory sensitivity factors, psychological factors, and other factors. So sensory sensitivity factors is actually your baseline sensitivity. People are different. You have some people who are tough as old boots and some people who are just more sensitive. So if you have a baseline of being a more sensitive person, unfortunately, if you get hurt, that's more likely to develop in CPS. Psychological factors we've talked about, and other factors, that's basically your context. So workplace injuries, collision-specific things, what does it mean to that patient? Hyperalgesia. So the way we can clinically assess for this, rather than just having to go through the patient's subjective findings or subjective assessment, is primary and secondary hyperalgesia. So hyperalgesia is increased pain to mechanical pressure, to temperature, or to chemical sensitivity. So basically, it hurts quicker than it should when someone pokes you, when you get in a hot bath, or someone spills acid on your nose. Hopefully we don't have any contacts with that, but we've got primary hyperalgesia and secondary. Primary hyperalgesia occurs in all injured tissue. So again, if I've torn my supraspinatus, that will always be more sensitive than it should be. It has to be more sensitive, so I don't use it as much. So I give it some time to chill and rest. Secondary hyperalgesia occurs in healthy, non-injured tissue that is normally next to or below that pain injury. So when I say below, I mean in terms of dermatomes. So C5, I start to feel pain in C6. The one way you can use this testing is with pain pressure thresholds, which is very simply poking with your thumb and finger. In research, they can use an algometer, which you can measure how much pressure you're using. That's a really nice way to get a consistent feed on how much pain they're feeling. But no one has conclusively said what is normal. So should you be able to have 5 kilos of pressure per inch, or should it be 10 or 20 or what? You can get something called a neuropen. It's got a 10-gram filament on one end, a 26-gram filament on the other. Everybody, for testing sensation, it's a great way to do it. The 10-gram filament bends when you put more than 10 grams of pressure. That has been classed as, what we know what's been validated for it. Everybody should be able to feel 10 grams of pressure. So if they can't, we know we've got sensory loss. Or if they say it's painful when it should just be soft touch, we know we've got some element of pain sensitization there. The 26-gram filament does pain. So again, if they can't feel, it's a little needle that has a spring, so it never will do more than 26 grams of pressure. If they can't feel the pain, then we know, again, we've got some sensory loss. So that could be in the periphery, spinal cord, brain, wherever. But again, you could use it over the painful area. How sensitive is that? Yeah, it's fine. How sensitive is that? Wow, that's really painful. Heat pressure threshold, we're just not going to use in clinic realistically. There are clever machines that will hold a temperature, 5 degrees for cold, and I think it's like 45 degrees for pain for hot, but I don't use it, say, and they're expensive. So realistically, we're not going to use them. And it's good because temperature is less sensitive than pain pressure thresholds. So what I mean by that is we will see changes in pain pressure thresholds, i.e. that doesn't hurt me, the same pressure over here does. So we'll see changes in pain pressure thresholds earlier than we will hot or cold pain thresholds. So for you clinically, really, you're going to be the one finding out, when I touch here, it's too sensitive. The patient might say to you, I can't stand hot baths anymore. I hate a hot bath, hot showers too much. I have it on cold, I have it on that tepid temperature because, I went out in the cold the other day and I just felt it as pain. Then that's the case. I had a friend once, she fell into a pond in the middle of winter once as a drunk student, and that reaction every winter, walking home from the student union back to the home, she would describe as pain because she had that long-term potentiation. That experience had been so bad that she's learned that cold is painful. So that's physiology. Let's get into the more even more terrifying, into neuroanatomy. So this diagram looks terrifying, but it's really not. I'm sure you will try to learn at university, as I did. I spent hours of my life trying to draw this out and remember it, and then be so disappointed when a year later I've forgotten it all again. And eventually I've realized it's because it's not all clinically relevant. What we need to know is the actual bits we use. Again, we're not the surgeon. We're not the one who has to spend, not a neurosurgeon who then has to spend another 3 years learning how to just operate on the brachial plexus because it's so complicated. All you need to know is that there are 5 roots. You know those roots already, C5 to T1. Those 5 roots grow, it's a tree, so those 5 roots grow into 3 trunks. Those 3 trunks grow into 5 branches. That's all you need. If you look at this diagram, you see it's divided into roots, trunks, divisions, cores, terminal branches. We don't need to know those divisions and chords. We just need to know there's an upper trunk, a middle trunk, and a lower trunk, or superior, middle, and inferior. Helpfully, the superior trunk and the inferior trunk are both anterior, so superior, inferior, anterior, and the middle trunk goes posteriorly. Now that is actually clinically useful. So if you want to make a note, that's a good one to know. So you've got 5 roots, they become 3 trunks, which become 5 terminal branches, 5, 3, 5, that's easy enough. The superior and the inferior trunks stay anteriorly, while the middle trunk goes posterior. And that's basically what you need to know. Those 5 terminal branches we do need to know, and we'll go through them now. Out of those 5 terminal branches, the musculocutaneous nerve is never going to come up in your practice. Have you ever seen anyone with a musculocutaneous nerve injury? I haven't so far, and I haven't met anyone, no one's ever put their hand up and say they had. The auxiliary nerve we should know, but how often does that come up in clinical practice? Not very often. So out of those 5 branches, actually there's 3 that are clinically important that we see all the time. So your myotomes and dermatomes. So I'm going to pause the video for a second, and I don't want to pause it, I'm going to reverse it. I want you to go through this and tell me where the myotomes and dermatomes are. So what I want you to do is literally on your arm now draw where the C5 dermatome is. And you should find it easy peasy. And then the C6 dermatome. And C7. And C8. And T1. Good, so hopefully that was very easy and you knew that they look something like this. So C5 coming over the lateral aspects of the arm, C6 coming down the lateral aspects of the forearm into the thumb and finger. C7 is obviously that middle finger stretching to the wrist. C8 on the lower, the ulnar aspects of the arm to the elbow, and T1 just above it. The myotomes are easy, right? So we got deltoids. Again, C5 is going to be your deltoids, going to abduct the arm from that kind of 15 to 90 degree angle. C6 is going to be mainly the biceps. Remembering this is a bit of a cheat because we're saying it's just one or the other. So C5, C6, C7, obviously there is a blend of those in there. So deltoids, we say primarily C5. If you want pure C5, however, you should go for rhomboids. So rhomboids has a, it's just pure 5, so that's a good one to do. Biceps would be C6, and wrist extension. C7 is going to be your triceps, and wrist flexion. Now, I always think it'd be so much easier if the neurology gods made it that C7 was extension of all of it, so triceps and wrist extension. So the way I remember it is super awkward. It's like triceps are, C7 is triceps, and it should be extension, but it's not, so it's flexion. So tear away, and if someone can think of a better way to remember it, then please let me know. So we have C8 is basically going to be kind of making that fist, and then T1 is opening and closing the fingers. Now, really, for me in clinical practice, just think C8, T1 is the hand. So if you want to remember it really easily, just think C5 is the proximal shoulder, C6 is going to be the front of the, it's going to be biceps, C7 is going to be triceps, and then just think C8, T1 hand. It's really easy. So, another terrifying diagram. It's so simple, this stuff. If we're looking at thoracic outlet syndrome, which is a common cause of radiating arm pain, we've got the scalenes. Now, interestingly, if you talk to a surgeon, they're going to say they don't see this very often, or never, because they think it's generally due to a cervical rib. Whereas if you talk to physios and chiropractors and manual therapists, we see mild neurogenic TOS all the time, where people are highly stressed out, they have this neck breathing pattern, the scalenes get hypertrophic, they compress those nerves. You might sometimes see puffing, like puffiness over the clavicle. Now, if you see that, we want to think Panco's tumor, even though Panco's tumor is actually very, very rare. So if you see puffiness, you think, okay, could that be a, like a tumor interfering with lymphatic drainage? But in my experience, it's normally that the scalenes got too big, they start to clamp down on structures. So you can see how we have the subclavian artery and vein right there. So TOS we all know about. What people know less about is pec minor syndrome. So we have brachial plexus comes out, it comes under the clavicle, and it passes under pec minor. You can see this in this picture. In pec minor syndrome, so in TOS, you classically going to say, I've got neck pain, and then pain going to the ulnar aspect of the hand. In pec minor syndrome, we're going to say proximal shoulder pain that travels into the armpit and down into the ulnar aspect of the hand. In both those TOS, you tend to hit the lower brachial plexus. So C8, T1, if the case is very bad, C7, and that's why it tends to go to the ulnar aspect. So TOS and pec minor look similar. Hopefully you're thinking back at your differential diagnosis slide notes earlier and thinking, ooh, does that sound similar to something I heard earlier in the day? So again, this diagram looks terrifying. You think, oh God, there's nerves everywhere. And I have tried to remember these over and over and over, and then realized I have never seen a medial pectoral nerve lesion. Why am I still trying to remember it? So dorsal scapular nerve is that branch to the rhomboids. So that's your pure C5. So if you wanted to think, well, C5 is not very common cause of radiculopathy, but it looks like it, I'm going to go and test rhomboids to see if that's true or not. Using deltoids is a little bit more mixed because you've got C6 in there, and patients are different. So different people have different things. So if you look at the end of this diagram, you can see they've got the numbers in red. So median nerve says C5, but well, you see that's an inconsistent distribution. So we have that on quite a lot of them, that people are different. So again, on this terrifying diagram, the bits you need to know are those 5 terminal branches. Muscutaneous nerve, just really uncommon. Axillary nerve we'll talk about. So muscutaneous nerve, basically you're going to have sensory loss over the lateral forearm. So it's kind of like it's basically in that C6 dermatome, but not going over not into the hand. you're going to have weakness of your biceps, and if you really had a case, you might see atrophy of the biceps, bicep brachii, all that kind of stuff. In this diagram, you can see how deep the musculaneous nerve runs below the biceps. It's deep beneath there. So really, it's stab wounds, shot wounds. So yeah, unfortunately, if you live in, well, I would have said if you live somewhere dangerous, if you live in London these days, you might see a stab wound injury, but they're not going to be presenting to you, right? Someone's not going to say, oh, hi, I've got stabbed in my arm and I'm feeling a little bit weak. Could you take a look? You're not going to have to differentiate this one. I have seen a case doing martial arts where basically razor sharp forearm against skinny bicep in like a blocking motion was enough to hit that nerve and basically induce like a temporary block. So if we're looking at nerve damage, we would call that a neuropraxia. The nerve is still perfectly intact. It's like a functional block. When you're writing to GPs or neurologists, you want to get into using the terminology. So, this patient has a mild neuropraxia affecting the musculaneous nerve. I expect it to recover within days to weeks. Versus, I suspect this patient has a complete neurotomesis, which is the nerve is completely severed. Please, can you refer for surgical consultation? So neurotomesis, the most severe, means the entire nerve has been cut. Poor recovery on that, even with today's amazing technologies, poor recovery. Whereas an axontomesis is the third kind, which is the middle ground. So neuropraxia, the most mild, recovers within hours to days, possibly weeks, assuming the compression has been removed. Axontomesis is the connective tissue is fine, but the axon itself has been crushed and has to regrow. Takes a little bit longer, so we're talking weeks to months. Neurotomesis, the most severe, taking months to years if we're lucky. This is a nice diagram because you really get a sense of where these nerves are coming. So you've got that brachial plexus. You can see it's coming down in front of the scapula. At the top there, we have the axillary nerve that's going to come off the posterior. It's going to pass, posteriorly, and it's going to give us that motor to the deltoids. So that's going to give us abduction from 15 to 90 degrees, but we're also going to see weakness of shoulder flexion extension because the deltoids has that anterior and posterior compartments to it. There is a little branch of that axillary nerve that innervates Sargent's patch, which is a little branch of sensation just underneath the armpit. Again, how often is a patient going to say, I don't feel my armpit? They might complain of weakness. Realistically, in clinical practice, we're going to see an axillary nerve lesion in crutch palsy. So you can imagine someone using crutches after having a knee surgery and they're leaning on that. Again, do we need to remember it? No. When they stop using the crutches, it's going to go away, unless they have a condition where they have to use it a lot. So, for instance, I recently saw a patient with this who has MS. So she's got MS. She's had it for 30 years. She's got basically weakness of both her legs, but her arms and face have been thankfully spared. So she's taking all the weight of her lower body on her arms, and that's enough to give her weakness in the shoulder. But again, the strategy is to be the same: reduce that compression, get her not to use it so much. So as I talked about Sargent's patch, we get weakness of the shoulder, abduction and flexion extension. We get weakness of external rotation. So bonus points if anyone can straight away think why. I'll give you a second just to have a little think about that. So the reason is because we have teres minor there. So one of the external rotation for the rotator cuff muscles, that's also an axillary nerve. And the deformity there would be wasting of deltoids. You basically see a strange bony shoulder. So I once saw a motorbike rider. He'd hit a tree head on, gone over the top of the motorbike, missed his head on the tree, but taken the impact with his shoulder and basically sheared off C5, C6, sheared those nerve roots right off. So the rest of the brachial plexus is intact. So he still has a perfectly normal grip strength. His forearm is all perfectly normal, but he has just pure bone on the shoulder. It's very strange to look at. That's a dangerous case for him because C5, 6, that's not just your deltoids, that's all your rotator cuff. So he's lost all proximal shoulder innervation, but he has good grip strength. So he's tempted to go to the gym and keep himself nice and strong and healthy, but when he picks up a heavy weight, he's going to dislocate his shoulder. So he's a patient where we want to say, oh God, yes, it's important to keep training, keep active, but within reason. You don't want to be lifting up heavy weights or any weights, maybe with that hand, to avoid that injury. So of all that information we got so far, now we're down to the 3 you need to know. So the median, radial, and ulnar nerve. Now I thought I'd go over this because every time I teach this in a live seminar, nobody knows them. So if I said to you, do you know what a carpal tunnel syndrome looks like? You say, yes, 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 easy, easy, easy. If I said to you, does carpal tunnel have sensory loss on the palm and the back of the hand? Hopefully you find that easy. If I say why, you wouldn't be able to tell me. So radial nerve is going to go to the back of the hand, but it's only the radial aspect of the back of the hand. The ulnar does the ulnar aspect of the back of the hand, as you see in that red and green diagram. The median nerve is going to do the rest. So it's going to do the palmar aspect, first 3.5 fingers, palmar aspect, and the first 3.5 fingers on the dorsal aspect as well. We're going to go through this in all more detail. So radial nerve. The radial nerve is on that middle trunk that goes posteriorly. So posteriorly means it goes under the armpit and it's going to go down the back of the arm. It is an easy one to remember because it basically does sensation down the back of the hand, up down the back of the arm, down the posterior forearm to the back of the hand, as we just showed you. So because it's right underneath the armpit, we could have a crutch palsy there that hits the radial nerve, or the classic one would be the Saturday night palsy, where you've been down the park, you've had too many drinks and fallen asleep with your arm over a bench, and you wake up in the morning with a radial nerve palsy. That would be, because it's right at the top, you'd have numbness down the whole of the arm. So when we start thinking about differential diagnosis, we want to start thinking through the level. So what nerve is affected and what level? Again, because carpal tunnel syndrome is the most common and cubital tunnel syndrome is the second most common in the upper limb, it's really easy just to see, oh, you've got numbness in the radial aspect of your hand, it must be in the palmar aspect of your hand, it must be carpal tunnel syndrome. Oh, it's on the ulnar aspect, it must be cubital tunnel syndrome. If you miss that it's not carpal tunnel, but it's pronator teres, then the patient doesn't get better, and there's consequences to that. So we want to start thinking levels. So sensory loss up at the armpit, the whole arm goes numb. It's going to go underneath the triceps along the back of the humerus. If we break the humerus, so I break my upper arm, we can shear the radial nerve there, in which case I'm going to have sensory loss from that part down. The radial nerve comes to the elbow. As it dives into the muscles of the forearm, it divides into a deep and superficial branch. The deep branch does motor, superficial does sensory to the back of the hand. So again, this time if I have like a supinator syndrome where I'm doing DIY in an awkward position, I can't get a power drill to it, I have to do it all by hand. If we get a fibrous supinator muscle or a muscle that's become too hypertrophic, we can trap superficial branch and just get numbness from there down. So some numbness above it would be fine, sensation above it would be fine, numbness from the down to the back of the hand. In terms of weakness, it's going to give you your triceps, and this is why I said it'd be easier if it gave us our wrist extension as well. It'd be really nice to just say, C7, radial nerve, wrist, elbow extension, wrist extension, finger extension, but it's not that. It's C7, elbow extension, wrist flexion. That sucks. So radial nerve is just everything down the back of the arm, which is really easy to remember. If we have a muscle weakness, the level of damage, that muscle is normally spared. So if I break my arm, my upper arm, at the level of the triceps, the nerve is sheared, the triceps at the level will be spared. So the triceps will still be strong, but we'll lose wrist extension, finger extension. Versus if I have a lesion at the elbow, I'll still have supination, but my finger extension will go. So the level of lesion spares the muscle. So in the deformity for a radial nerve lesion would be that wrist drop. Now, radial nerve lesions aren't nearly as common as median nerve or ulnar nerve, but it's worth remembering, especially when patients start presenting with radiculopathies, pain traveling down, and they might easily say pain goes into the back of my arm and then into my into the back of my hand, we really don't want to think, is it a radiculopathy or could it be something else? Because if you start treating radiculopathy for weeks and you're wrong, you've got an unhappy patient there. So median nerve, it's basically give you, as we show, the median nerve is only going to give you sensation in the palm, in the radial aspect of the palm, nothing above it. So median nerve gives you the vast majority of the muscles of the forearm. Ulnar nerve gives you the vast majority of the muscles of the hand. Ulnar nerve we think of as the artist's nerve. It's the ulnar nerve that gives us our fine coordination and allows us to do, all the amazing things that humans can do with their hands. The median nerves gives us the power in our forearms, our grip strength. So that's me jumping ahead of myself there. When we look at muscle testing, there are so many muscles in the wrists and in the forearm and in the hand that it is a nightmare. And there's so many different, so many ways you could do this. I'm going to suggest to you the best way to think about it is looking at the thumb. Thumb has radial nerve innervation, median nerve innervation, and ulnar nerve. So very simply, if you put your thumb and your thumb and little finger against each other, we call that opposition. That is your median nerve. So your median nerve gives you that opposition. It does the thumb, that's the median nerve, and the ulnar nerve does the little finger. So if you wanted to test ulnar nerve and median nerve just very quickly, little finger and thumb are opposed. Pull the thumb, median nerve, pull my finger, ulnar nerve. So you can do it all just with the thumb. So opposition is median nerve, and we can do flexion. So flexion in the thumb is actually how do you describe it? So it's bringing it kind of towards my elbow, towards the kind of front of my elbow. So adduction is ulnar nerve, opposition is median nerve. So adduction would be bringing my thumb alongside my first finger. Opposition is bringing them opposite to each other, little finger and thumb opposite. So if we want to do adduction, that's ulnar nerve. Opposition is median nerve. Extension, so bringing my thumb backwards towards my olecranon, towards the back of my elbow, is radial. So if you forget everything else and you want to know is median radial nerve quick, easy. Extension is radial nerve. Adduction is ulnar nerve. Opposition is median nerve. That's that simple. If we have a median nerve lesion, so let's go through them. As the median nerve comes down the front of the forearm, it's going to pass deep in between the two heads of the pronator teres on the forearm, where we have that pronator teres. Now, guys, I'm going to see if I can just switch you so you can see me rather than this. No, I can't. Okay, sorry guys, you're gonna have to put up with the slideshow instead. So it's going to pass down through the pronator teres. It's going to then pass along the front of the forearm, where it's going to give a branch off to the anterior interosseous nerve. It's then going to continue down. So anterior osseous nerve is motor only, so it's a branch of the median nerve. The median nerve itself is going to continue down to the wrist, where it's going to go through the carpal tunnel. If we have a pronator teres syndrome, so think again the DIYer who's doing a lot of pronation with their wrist and they get a big fibrous pronator teres, we can lose everything below it. So pronator teres will continue to be strong, but we'll lose anterior interosseous nerve, and we'll lose the median nerve continues down. So that will give us a loss of sensation in the hand, the fingers, and the palm. So in carpal tunnel syndrome, if I said what fingers are affected, you would super quick say the first 3.5 fingers, and we'd all celebrate. If I asked you, is the palm also affected or not, you'd probably scratch your head. So the sensory branch to the palm, the superficial branch to the palm, breaks off before the carpal tunnel. So in carpal tunnel syndrome, if the palm is also numb, it's not carpal tunnel. It's higher than that. It must be pronator teres. So when we test that, when the patient gives you something vague like my whole hand is numb, we want to go and test, which fingers specifically, and they should be able to easily feel the difference, and is the palm affected. If the palm is spared, the fingers are numb, the palm is spared, we know it's carpal tunnel. If the palm is also numb, we know it has to be above that. It can't be anterior interosseous nerve because there's no sensory branch to the anterior interosseous nerve. So it must be the median nerve at the pronotaries. The anterior interosseous nerve allows you to make an OK sign. So if you put your first finger and thumb and just give someone a nice big OK, it's the anterior interosseous nerve that allows you to flex. So it's flexor pollicis longus. So it allows you to flex the distal tip of your thumb and make that OK sign. So again, if you ask someone to say, give you an OK sign and their thumb is flat, that's no good. The classic way to test this is to get someone to pinch a piece of paper. Is to pinch a piece of paper and they have to keep their thumb in an OK sign. And then when you pull, it's going to pull their finger flat, their thumb kind of into extension basically. The hand of benediction is basically that the flexor palmaris longus has a median nerve and an ulnar branch. The median branch does the first and second finger. The ulnar branch does the fourth and fifth. So when the patient then tries to make a fist, because the ulnar branch is still intact, the fourth and fifth fingers curl, but the first and second stay up. Now, I'm not a religious man, not a holy man, but apparently that is it's called hand of benediction from a religious sign, I guess. So if you again wanted to be lazy and you were doing your SMR assessment and you just want to have a quick look at median nerve and ulnar nerve, because that's perfectly reasonable, they're the two most common upper limb peripheral nerve entrapments, you could just have the patient curl their fingers and just test first and second, index finger, and depending on how you count them. Do you count thumb as your first finger and index finger second, or do you say thumb is its own thing and first finger, second finger, third finger, fourth? So do you have a thumb and 4 fingers, or do you have 5 fingers? So I'm going to say thumb is number 1. So you would have the patient curl their finger, and you're going to test second and third finger together. That'll be median nerve, and then fourth and fifth finger, and that's your ulnar nerve. So just to recap that one more time, median nerve at the pronator teres syndrome, you can have pain at the elbow, numbness into the palm and the fingers, as well as weakness. They can't make an OK sign, and they wouldn't be able to oppose the thumb. So, oh my God, the names, opponus, no, pollicis, opponus, ponus, pollicis, something like that. Complete, got out of my head. My mistake for not having dinner yet. So they wouldn't be able to make a K sign, and they wouldn't be able to oppose their thumb. Both would be weak, but pronator teres would be strong. If someone comes and I'm playing rugby and I have a bad tackle and someone smashes their knee into my forearm and we hit the anterior osseous nerve, I would complain of no numbness in my hand at all. My hand would feel perfectly fine. I might have pain radiating to my hand, but my palm would feel perfectly fine, but I wouldn't be able to make an OK sign. If it's at the carpal tunnel, I would still be able to make an OK sign because the motor branch has come off at the anterior interosseous nerve, so I can still make an OK. That's AIN is OK, but I wouldn't be able to oppose my thumb. So we'd have that weakness of a ponus pollicis longus. As soon as I cut out this call, it's going to hit me, isn't it? Right, on the nerve. So sensory loss. It's going to give you that numbness over the hypothenar eminence and the kind of ulnar aspect of the hand. So again, it's going to give you the ulnar aspect of the palm and the 1.5 fingers of the 4th and 5th fingers. In terms of the cubital tunnel, that's more common. So we've got the two main ones are going to be cubital tunnel syndrome and tunnel of Guillain. Now, tunnel of Guillain is going to be the wrist, very common in cyclists, whereas cubital tunnel is going to be more common in people who sit with their elbows flexed. So there's going to be people that are at desk all day, people who like to read for long times, people who spend a lot of time on our phone, which is basically everyone. If you take a piece of paper now and just run the corner of the paper along your index finger and along your little finger, you may well notice the difference between one and the other. For me, it's my ulnar nerve in the finger is a little bit dull compared to the radial nerve, and that's because I got long arms where that ulnar nerve gets tractioned over the elbow a lot. Unfortunately, I have a slight kind of snapping on the nerve that kind of pops out of the cubital tunnel. So you imagine over time that does damage, and that's why I've got a little bit of sensory loss there. Most of you, being hard-working people, will find that there is a slight difference between side to side, and unfortunately, people, that is signs of nerve damage. What a depressing way to get to the end of this lecture. So I said earlier, the median nerve is the forearm, whereas the ulnar nerve is really more the hand. So in the forearm, it does do wrist flexion and adduction, which is your flexor carpi ulnaris. But that's pretty much it. So it's flexor carpi ulnaris, and that's basically it. Everything else is median nerve. In the hand, we can overcomplicate things. Just remember, it does adduction of the thumb. So as you adduct your thumb, so your thumb is now lying alongside your first finger, everything's going to move in adduction. That's the way to remember ulnar nerve. So we adduct the thumb, and we also adduct the little finger. That's the way to remember it. If they're both weak, you know you've got an ulnar nerve weakness. The way to do that Froment sign is you put a piece of paper in between the thumb and the first finger. Both fingers are straight, and then you're going to have the patient pinch it and try and pull it away, and you shouldn't be able to pull it out. And if you can, you know there's probably an adductor pollicis weakness there, so it's going to be an ulnar nerve lesion. I saw my first claw hand this week, or last week. A patient, poor guy, another motorbike rider, had a crash 30 years ago, and he had a hangman's fracture, so he should have died. It wasn't picked up, but one of his injuries was he broke his elbow, snapped his humerus, and again completely sheared the ulnar nerve. So because the ulnar nerve is completely gone, he's ended up with a claw hand. So basically, you get hyperextension of the proximal metacarpal phalangeal joints, and you get flexion of the distal ones, of the distal dips. So basically, you end up with a very strange looking hand where the hand is kind of extended, but the tips are flexed. And that's the first one I've ever seen, but you're not going to see it very commonly. If it affects the whole hand like that, you know you've got a high ulnar nerve lesion, or it could be brachial plexus. So if you see a true one like that in clinic, it's broken, that patient's straight out the door. It's rare to have it complete like that. What you often see is maybe the third, fourth and fifth finger will be affected. And again, opening and closing the fingers, so adducting them all, and adducting and abducting them all. Those lumbrical muscles, so that'd be another way. So just having the patient open, spread the fingers nice and wide. Again, that's going to be a ulnar nerve test. So again, if we work our way through differential diagnosis, and I appreciate we're just running over time here, guys, so I'll try to wrap it up soon. If it's the cubital tunnel, second most common upper limb peripheral nerve entrapment, and the most common ulnar nerve entrapment, we're going to still, if it's above the elbow, we'll lose flexor carpi ulnaris, so we'll have weakness of being able to flex and deviate my wrist to the ulnar aspect. But in particular, we're going to have weakness in all the muscles of the hand that are, that flexor palmaris ulnaris, flexing your fingers, adducting the little finger, adductor digiti minimi, so adducting the little finger, and adducting the thumb. If we spare the elbow, and it can be above the elbow or it can be below, if it's below the elbow, really kind of as the nerve passes through the forearm muscles, we will spare that flexor carpi ulnaris, and we'll just have weakness in the hand. The sensory loss, though, would be in the palm of the ulnar aspect of the hand, and if we just go back, would be in the palm of the, let's just give you that picture. So it's going to be in the palm and the fingers if the entrapment is at the elbow. If the entrapment was at the wrist, we're just going to have the fingers. So it's like the median nerve. If the entrapment is at the carpal tunnel, all that palm area is spared, it's just the fingers, the 3.5 fingers. If it's above, if it's cubital tunnel, if it's tunnel of Guyon, we're going to we're going to spare that palm, and we're just going to hit the fingers. Tunnel of Guyon can be just sensory, so a patient can just complain of numbness in the fingers. It can be purely motor, so we get weakness in the adductor digiti minimi and the adductor pollicis, or it can be both. Again, the classic one is it's worse when they're at a computer, or it's worse when they're cycling. Right, let's just skip back. So if you were thinking back about the case we started with, proximal shoulder pain, pain traveling into the ulnar aspect of the forearm, into the hand, but he complains at nighttime the whole arm is numb, the whole hand is numb. hopefully he's picked up on that pec minor syndrome. So he's got that pain in the chest. It might have referred into the armpit occasionally, and it travels down because it hits C8T1. It travels down to C8T1 dermatomes into the hand. Worse when he does press ups, when he does bench press, when he's sitting at a desk with rounded shoulders, which is what the pec minor does, right? It flexes, anterior, rolls our shoulders anteriorly. When we have that weakness, that numbness in our hand, he can have numbness in that distribution, right? So at nighttime, carpal tunnel syndrome kicks in because that's when we get more edema. A lot of people sleep with their wrist in a flexed position, which compresses the carpal tunnel and results in more edema. You shut off the carpal tunnel. Now, patients are lazy, so he'll say my whole hand is numb, but he's basically saying everything but the palm is numb. So that's why you need to go in and test. If it is the palm as well, then we want to think, okay, if the palm is there as well, could it be peroneal artery syndrome? Or, what would it have to be to hit the entire palm? Well, it has to be quite a lot, right? You'd have to hit C6, C7, and C8. Could it be a plexopathy, like a brachial plexopathy, where we've had brachial neuritis, where we get an infection in? If we had an infection in brachial plexus, we tend to complain more of severe pain in the kind of proximal shoulder and neck, really terrible severe pain that subsides over about 2 or 3 weeks and is replaced with profound weakness. So a patient who's like, wow, my neck and shoulder are awful and my whole arm is on fire, is so painful. It's not made worse with any neck movements or any of your provocative tests. And then that pain suddenly goes, but they're left with profound weakness. We need to think, okay, it's probably a viral brachial plexitis, plexopathy. Time normally gets it better. So if we're looking at low-level laser therapy or photobiomodulation, it is the same thing. There's a complaint with using the phrase low-level laser that we're looking at different wavelengths of light. So when we clump everything under low-level laser, we're talking about thermal and non-thermal. So when we're talking about the Erchonia laser, we're talking about non-thermal lasers, which is different to low-level laser therapy, which might also include infrared. So infrared is going to work through thermal effects on cells, which is great. Still, it can still have its place. When we're talking about photobiomodulation, we're talking about there's photochemical reactions on the cells. So it works through a different principle. So 2 to 4 weeks of low-level laser therapy in carpal tunnel syndrome. So because the research does get a bit messy, because they do often just look at, they tend to clump all low-level laser therapy together. What I've done, instead of just choosing instead of cherry picking data, what I've done is looked at systematic reviews and said, okay, overall, does it all work or not? So what we see is 2 to 4 weeks of low-level laser improves hand grip strength and significantly improves pain for both mild to moderate carpal tunnel syndrome. You won't see any studies on severe, because in severe it's broken. So in severe, we want to refer out and have someone basically do surgery, because it's quick and relatively safe. So for mild to moderate, we might want to treat that rather than having to, patient might not want corticosteroid injection, they might not want to go through steroids. So low-level laser is a safe alternative to that. There's strong and moderate evidence for the effectiveness of low-level laser in the short term, so up to 7 weeks. There haven't been any studies last time I looked at this, so last reviews, I think 2018, 2020, they still haven't done any long-term studies. So they know that it's effective up to about 7 weeks. They haven't looked to see if that benefit continues on for 3 months or 6 months or longer. But in the short term, strong to moderate evidence for the effectiveness of low-level laser in the wrist. And often, as is the way with low-level laser, oh my God, I'm doing bad with the tongue twisters today, aren't I? As is the way with low-level laser, it often works best if we're using it in combination with things. So using it in combination with a splint has the highest probability for reducing pain. There was another study that looked at this into using lasers and myofascial release, and again that had a better outcome than myofascial release on its own, or myofascial release or laser on its own. So that's why it's a nice thing for us to be using in clinic, because it's adjunctive to what we do. So you don't suddenly stop everything and become a pure laser therapist. You take all the skills you already have, all the knowledge you have, and you just add the laser in to give you that bit more of a benefit. When they did that one with splinting, it was an interesting study where they were looking at systematic review and trying to do a meta-analysis and things like that. There was too much heterogeneity between studies. So there was too many differences between studies to categorically say, we know that low-level laser plus splinting had the higher probability. Although it was statistically the best or statistically significant, they didn't find it was clinically better. So although statistically it was the best at reducing pain, the clinical difference between the different ones wasn't significant enough, but that's partly down to heterogeneity. So as is the party line, more research, more research. So one meta-analysis, I think this is found that, yeah, sorry, the last one wasn't a meta-analysis, that was a systematic review. And like I said, there was too much heterogeneity for a meta-analysis. The only meta-analysis was this one from 2017. They found good evidence for the use of low-level laser in treatment of musculoskeletal. Oh, I'm getting my research all confused. This is for using low-level laser in general musculoskeletal disorders. So basically, my reason for including that there is, again, this idea that as a therapist, you're probably not only seeing cuffed on its own, you're going to be seeing a patient who comes in with neck pain, shoulder pain, and arm pain. And like my patient, you're trying to differentiate, is this at the neck? Is this at the shoulder? Is it down in the periphery? And low-level laser is just a nice way to be able to say, cool, I've got a tool that can do all of that. It's pretty robust, so I can do my standard manual therapy chiropractic stuff on the neck and shoulder. I can do some myofascial release on the peroneal teres on the wrist, and then I can use low-level laser to reduce inflammation, reduce pain, and improve strength. So, guys, thank you. I realize I ran a bit over there. Thank you very much for sticking with me. And I apologize I couldn't get the camera to work so you can see my hand gestures. I promise you I'm waving my hands all around. So if you do have any questions, you are very welcome to contact me at jake@clinicalneurologyseminars.com. There's the Facebook page and the website. If you have any questions, please get in touch. And yeah, thank you very much. I appreciate you taking the time to listen to me talk on a Monday evening. Very impressive, very enthusiastic of you. That's it. We're done. Have a great evening. And hopefully we'll speak to you all again soon.